everybody. My name is Aleksandra Rachitskaya. I'm from Kola Institute Cleveland Clinic, and I'm excited to be here today for the new Retina Radio Journal Club that we're doing together with VBS. During these journal clubs, we discuss the recently published papers. We summarize the paper for you and then have a little bit of discussion what it means for our practices. I'm delighted to be joined today by my friends and colleagues. And first up, we have Mrinali Gupta, who practices at Retina Associates of Orange County, California. Mrinali, how are you today?
Doing well. Thanks for having me.
Awesome. And we have Eric Nudleman, who is at Shiley Eye Institute, UC San Diego. Eric, your weather's probably better than mine. How are you?
Doing great. Yeah, it was a beautiful day. Thanks for including me.
Of course. And we have Aris Thanos from Legacy Devers Eye Institute in Portland, Oregon. Aris, how are things with you?
Everything is going great. Thank you for having me.
Oh, it's my pleasure to be with you guys here today. And we're going to talk about a paper that I think is very interesting and probably something that we see maybe weekly in our clinics. So what we're going to discuss is one of the DRCR studies. And this is the study that looked at effects of intravitreal aflibercept versus vitrectomy with PRP on visual acuity of patients with vitreous hemorrhage from proliferative diabetic retinopathy. And this is the paper with the lead author of Andrew Antashik. And as I mentioned, this is a DRCR Retina Network study. It was published in December 2020 in JAMA. And I'm going to let Aris summarize the paper for us before we go into the discussion.
Great. So the DRCR in this protocol AB, is mentioned, they compared two treatments, basically intravitreal aflibercept compared to panretinal vitrectomy with panretinal photocoagulation. They enrolled 205 patients with vitreous hemorrhage from proliferative diabetic retinopathy. We should mention that the vitreous hemorrhage was varied in duration from less than 1 month to more than 12 months, with more than 80% of both groups having a vitreous hemorrhage of less than 3 months. Also, we should notice that more than 50% of patients had some form of prior treatment for either DME or proliferative diabetic retinopathy, and that either included panretinal photocoagulation or anti-VEGF. And patients were randomly assigned to one of the treatments, and the aflibercept group received 4 monthly injections, whereas the panretinal vitrectomy group had surgery within 2 weeks. Patients could cross over to receive the other treatment if the first treatment had failed. The primary endpoint of the study was the mean visual acuity letter score area under the curve at 6 months. And the secondary 24 weeks, and the secondary endpoint was the mean visual acuity at 4 weeks and 2 years. So the outcomes of the study, show that at 24 weeks, there was no significant difference between in the mean visual acuity letter score between the two groups. However, at 4 weeks, those in the panretinal vitrectomy with PRP group had significantly better vision. That was 2100 for the aflibercept group, compared to 20/60 in the panretinal vitrectomy with PRP group. By 2 years, though, both groups, had identical visual acuities, and that was approximately 20/40. The study authors concluded we should mention that the study was powered to detect an 8-letter difference, and they concluded that the study might have been underpowered, considering the range of 95% confidence interval to detect a clinically important benefit in favor of the panretinal vitrectomy and PRP group.
Aris, that's a great summary. So maybe I can ask Eric on his initial impressions of the study when you first read it. What was your reaction?
Thanks, Alexandra. So first of all, I think that the DRCR should be congratulated for giving us another very practical and clinically relevant study. They've just been fantastic in answering longstanding questions in our field. And here's another one. Most of the studies that looked at the differences between treating with anti-VEGF versus vitrectomy have been retrospective. So here's a prospective study, gives us clean data. And what we found is that it's roughly equivalent. So this tells us that for patients that are monocular, need to have quick vision restoration, vitrectomy is a very reasonable option. For patients who have good vision in the other eye, prefer not to go to the OR, it's totally reasonable to treat with an anti-VEGF and wait it out. It's really helpful to know that ultimately the vision results are equivalent.
Yeah, it was probably a little surprising, you know, to see these results for me. Mrinali, what are your kind of take-home points on a first glance?
Yeah, I think I would echo what Eric said. You know, the top line finding is that the long-term outcomes are similar, whether you treat medically with anti-VEGF or you go to the OR. I think it's an amazing study. It's been a long time since we looked at vitrectomy and diabetic retinopathy, and the diabetic retinopathy vitrectomy studies were done in the 20-gauge era before widespread endolaser application. So studying today's vitrectomy against today's gold standard medical treatment is really an important piece of data for us. And I think that most of us will probably use this data to individualize our treatment. As Eric alluded to, some patients may choose to elect for medical therapy, whereas others who might want to be rehabilitated faster from a visual standpoint because they're monocular or work requirements or whatever, you might go to vitrectomy sooner. I think it's important to note that the anti-VEGF group did not get laser. And so some of the findings don't echo what I personally do clinically when I medically manage these patients, which is I watch them or inject them with anti-VEGF. And then when the view clears, I put laser in. And I wonder if that's why, although the visual outcomes are similar, the medically managed group had much higher rates of persistent NV, recurrent vitreous hemorrhages, TRDs developing later on. So that leads me to wonder if part of that is the lack of PRP that was done, or part of it is the lack of removing that vitreous scaffold. And I think that remains to be seen based on this study, but nonetheless an important study.
So awesome comments and great summaries. So we're going to take a little break before we go and a little bit more in-depth discussion on this study. Stay tuned. Welcome back, everyone, to the new Retina Radio Journal Club that we're doing together with VBS. I'm Aleksandra Rachitskaya, and I'm joined today by Mrinali Gupta, Eric Nudleman, and Aris Thanos. And we're discussing one of the DRCR Retina Network studies that compared intravitreal aflibercept versus pars-plana vitrectomy in patients with vitreous hemorrhage. And as was mentioned earlier, I'm also very impressed how DRCR Retina Network has expanded the types of studies they're doing. And the surgical studies are always hard to do. You know, they're much more involved than some of the just in-clinic treatments. So as we think about the study, maybe I'll ask you, Aris, what do you think about the study design, and anything that you think could have been done differently to make it more applicable to our day-to-day practices?
Yes, overall, the study design is it's very well done. I think the main point that I would like to raise, looking at the table with the baseline demographics of the patients, is that there is a significant percentage of type 2 diabetics compared to type 1. It's mostly 80% of type 2, and in both groups. And looking back into the diabetic retinopathy vitrectomy study, at least some important information that we got from this study is that the vitreous hemorrhage, the outcomes after vitrectomy between type 1 and type 2 diabetics are different. So, certainly in the era of anti-VEGF, it would have been also very, very compelling to see how type 1 diabetics versus type 2, with modern vitrectomy instrumentation, how do these perform? And especially, it would make a lot of sense, for example, in a young patient to do a complete vitrectomy with PRP to remove the scaffold for neovascularization and potentially treat the disease once and for all, compared to basically keep doing serial anti-VEGF injections. So that's one of the points that I would like to raise.
So very, very good point, Aris. You know, I think when it comes to diabetic population in general, these are very heterogeneous kind of presenting patients. You can have patients with just vitreous hemorrhage, or you can have patients who have DME that's hiding under the vitreous hemorrhage. And vitreous hemorrhage in and of itself, it can come from somebody just having NVD or somebody having actually fibrovascular proliferation, which is a very different kind of patient. And as you mentioned in the study, for some patients, their prior history was known, but not for everyone. And if you don't have a view and you rely on ultrasound, it's very hard to determine exactly what other issues are going on with these patients. So I think that also might translate to some of the adverse events that were seen in the study, because some of them were a little surprising to me if I think of just my regular practice. Mrinali, what did you think of the adverse events that were reported in the trial?
Yeah, just as a quick summary of some of those. So the risk of a TRD when the view cleared, so spontaneously cleared in the aflibercept group or was cleared surgically in the vitrectomy group, was similar between both groups. It was 12 or 13%. The risk of a cataract or need for cataract surgery was similar between both groups, which I thought was interesting, since one group is getting vitrectomy surgery, and that's something that's always on our mind, especially with young diabetics. But there were some others where the groups differed. So the risk of finding a TRD later on in the course of the study was higher in the aflibercept group, 9% versus less than 1% in the vitrectomy group. And again, I don't know if that's because the aflibercept group didn't get PRP as part of their treatment, and they were only getting 8.9 or 9-ish injections over 2 years, or if it's because the vitreous scaffold is still there. That's not clear to me. But there were some that were interesting. The risk of a new or worsening regmatogenous retinal detachment, I think, was in the 4 or 5% range, which I think is higher than any of us anecdotally feel is the case with either medical or surgical treatment of these patients. Endophthalmitis was in the 1 to 2% range, which again is higher than what we quote for intravitreal injections or for patients undergoing surgery. So just things that are a little bit unusual that kind of draw our attention. And I'm not sure if those endophthalmitis were culture positive or were sterile endophthalmitis in the setting of aflibercept, or inflammation in a post-op patient, or a TAS-like process. But nonetheless, there were higher rates than clinically experienced of endophthalmitis in this study.
Yeah, that's very interesting. And I think, when you have a clinical trial, you kind of report what you see. And, it's, as you mentioned, anecdotally, that might not necessarily be the case. But once again, once somebody is assigned to an arm, you continue with that. Whereas in clinical practice, you can modify things from visit to visit. So thinking about how we can apply the results of this trial to clinical practice. So Eric, did it change the way you treat the patients? What did you think about your everyday practice and the patients that you see with vitreous hemorrhage?
Yeah, I thought it was actually quite close to how I generally approach patients with vitreous hemorrhage, diabetic patients with a vitreous hemorrhage. I like that the study design allowed you to cross over. So the patients that were being treated with aflibercept that had a a hemorrhage that persisted beyond 2 consecutive injections were allowed to have a vitrectomy, and vice versa. Patients that had a vitrectomy that had a persistent hemorrhage after surgery could be treated with an anti-VEGF therapy, which is what I do. So I think these were very practical results, and in terms of what I do with patients, I think it sort of validates the approach I take, which I mentioned early on is, patients who require a faster recovery, if you want to hasten recovery, then I think surgery is a great option. And for patients that prefer not to have surgery and can wait it out, particularly if you're confident that there's not something underlying there that's dangerous, with an ultrasound or with a limited view, continue with treatment with an anti-VEGF is totally reasonable. There are, of course, those patients who have had a hemorrhage for a very long time, and it's dehemoglobinized, and that may be dense dehemoglobinized blood in a young patient with formed vitreous. Those patients typically do not benefit from continuing with an anti-VEGF therapy, and I generally prefer to go straight to the OR for them. That wasn't really discussed in this paper, but I think we're all familiar with that scenario.
Any other comments, Mrinali or Aris? Aris, how does it change your practice at all?
I think more or less, especially in a new patient who shows up in my clinic with a new vitreous hemorrhage, I think I will still start with an anti-VEGF, 1 or 2 injections, and if the hemorrhage doesn't clear, I will offer him the vitrectomy procedure. But certainly, from seeing it from another point of view, if a patient who has it's the 3rd or 4th recurrent vitreous hemorrhage, and then he's tired and he wants a quick recovery, then I'll offer him again a vitrectomy. So certainly it's good to have a randomized clinical trial reinforce our decision making. So it's excellent work.
Mrinali, any last comments?
No, I think it's a wonderful study, and I echo what Eric, Aris, and you've already mentioned, which is that it's nice to have some data to present to patients for that subset where you do go in early, whereas before we were kind of doing that because of monocular status or bilateral hemorrhage or patient preference or whatever. It's nice to have some long-term data to share with them to give them a sense of what their options are and what the outcomes are likely to be.
I agree. And I think it really helps with discussion that you have with the patient, as you have all mentioned. You can phrase it in many ways, but ultimately, if a patient comes with a vitreous hemorrhage, you can say, we can start with this kind of a step-ladder approach. We're going to try the injections. We know from the studies that approximately a third of patients will need surgery, but 2/3 don't. So, you kind of have that data to go on, as opposed to, just saying, oh, you might or you might not need surgery. So I think it's very powerful in that regard. And also the same way with the patients where you think they might need a sooner surgery, you can also mention that, patients, even after surgery, might need additional anti-VEGF treatments. So I think it helps in that kind of discussion as I take it to my clinic. So I would like to thank all of you for participating and discussing this paper. And I would like to thank all our listeners for joining us for this journal club that is done together by New Retina Radio and BBS. And please stay tuned for our future episodes. Thank you so much.